Good afternoon, everyone. Thanks for being here. I'm Brandon Block, and I cover housing and homelessness for the Olympian. I'm excited to host the Olympian's first live event of the year, which explores mental health, policing, and public safety. Just a quick programming note before we begin. We invited law enforcement leadership to join us for this conversation, and Deputy Chief Sam Costello had previously signed up. However, we were informed earlier this week that the city had concerns with some of the topics covered in part 2 of my article, which was headlined, "Should Olympia Reallocate Law Enforcement Funding to Social Services?" A representative for the city expressed that when Deputy Chief Costello agreed to join the event, they understood it would entail only questions about the crisis response unit and not about other aspects of police reform. Further, they did not want him to participate in a conversation that involved quote-unquote defunding the police. With that said, I'm pleased to welcome our guests today. We're joined by LARSEN, Outreach Services Coordinator for the Olympia Police Department, who has headed the crisis response unit since it began in 2019. We're also joined by MARILYN Roberts, the Director of Operations for NAMI Thurston Mason, a local affiliate of the National Alliance on Mental Illness. Welcome, Ann and MARILYN. Thanks for being here. We've already received a number of interesting questions from our readers, but if you haven't submitted one yet and are feeling inspired, please do post your questions. You can post them in the comment thread on our Facebook and YouTube pages where we're live streaming this event. So before we begin, just a little bit of context. 2 years ago, Olympia became the second city in the nation to send unarmed mental health workers instead of police officers to respond to some 911 calls. I went on several ride-alongs and spent months talking with members of the crisis response unit, which is now set to double in size from 6 to 12 responders. Lawmakers in Washington state this year passed new police accountability legislation that is among the most ambitious in the nation. Since then, police departments in Olympia and elsewhere have pulled back from engaging in mental health and social welfare calls, which make up about 21% of all 911 calls in Olympia. As cities across the state and country rethink their approach to public safety, Olympia's program stands out as a national model. So let's dive in with some questions submitted by our readers. I want to start off with the basics. Nancy from Olympia wants to know, what type of calls does crew respond to? Can you give some examples? And a similar question from Duncan, who asks, how do they get dispatched? Does law enforcement stand by in dangerous situations? So Anne, maybe you can take the first one.
Sure. So really, the type of calls that crew responds to really have the nexus of the call is typically poverty, behavioral health, or substance use. For folks that are in Olympia and listening to this from Olympia, you know that we have a really large houseless population. So a lot of our calls do have the nexus of the origin of the call would be poverty. A typical call for the crew team might be someone that's not successful in shelter. So maybe they are trying to be successful at a night at UGM and they're having some big behaviors because maybe something had gotten stolen from them earlier in the day. And we really want folks to be successful in sheltering overnight. So the crew team might come to de-escalate that situation. We do respond throughout the city of Olympia. So calls for folks that are housed might look like someone home from college that's having some suicidal ideation. Parents are concerned. They call 911 and the crew team is dispatched.
So I have a kind of bigger picture question as well, and you can take this in whatever direction you want. What is the impact of having something like a crisis response team? And specifically, how have things changed since it launched in 2019? It's been just over 2 years. So maybe MARILYN, can you start with that, and then we can go to Anne?
Sure. I think it's a great plan. Nationally, NAMI has supported using mental health professionals instead of police to go out to those calls. I've heard great feedback for people who have come to our organization to ask for that education and that advocacy piece that they're looking for to go out and take care of that loved one. I've heard nothing but great things about the COATS model and the City of Olympia crew.
And you mentioned cahoots. Can you just briefly explain to anyone who's not familiar what cahoots is?
I think Anne would probably do a better job at that.
Yeah.
Sure. So our crew team is based strongly off of the Cahoots model, which comes from Eugene, Oregon, and they have been up and running for 31 years. So our former chief, Chief Roberts, came from Eugene before he was chief up here in Olympia, and he retired in December of 2019. And one of Chief Roberts' visions was to have a Cahoots type model here in Olympia. So what that looks like down in Eugene, and we're really strongly based off that model, is it's civilian first responders that are on police radio responding to calls for service in the community, really truly based on those three kind of pots: that poverty, behavioral health, and substance use. In Olympia, we do also see medical and disability and domestic violence at times for reasons that we're responding. But the Cahoots type model is based on 4 principles: street outreach, harm reduction, trauma-informed, and culturally competent care. And that's really what we strive to do here in Olympia with our crew team as well. All of our calls for service are occurring in the community. And so we're not sitting around waiting for a call to service. We are out in the vans or out walking around, engaging in our community and responding to people in crisis where they're at, whether it be at their house, in a hospital, in the streets, in an encampment. And yeah, so that's the Cahoots type model. And like Brandon mentioned earlier, we are the second in the nation to implement this type of response to our community, and it's been growing ever since.
And Anne, you mentioned police radio. Can you talk a little bit about how people can call crew and what that response looks like? How do they get the call, and how do they that process?
Absolutely. So we keep track of how we make contact with community members. And so there are multiple ways that the crew team is having contact with folks in our community. So one of them is TCOM or 911 here in Thurston County. So individuals in the city of Olympia can call 911 or their non-emergency number and request the crew team. Currently, the crew team is operating 7 days a week. 7 a.m. to 8:40 p.m. Monday through Thursday, and 10 a.m. to 8:40 p.m. on Friday, Saturday, and Sunday. As Brandon mentioned earlier, we are expanding our hours and really working towards a 24/7 response. But I just wanted to give folks kind of that parameter that's the hours that we're operating in currently. And so folks can call 911. The crew team does self-initiated contacts, so that might look like they see something in the community. They're out driving and they see somebody without shoes on, and it's 28 degrees, and that person maybe is weaving in and out of traffic a bit. We kind of know that might generate a 911 call. So instead of pushing the community into calling 911, the crew team would just pull over and engage in that individual. We get requested by law enforcement specifically. So an officer may respond to a call for service. They arrive, they realize this is not a law enforcement call, and they request the crew team directly over the radio. Law enforcement may call them on their cell phones as well. And then we get requested by our fire department. A lot of times folks that have low-level medical conditions that fire are responding to may also have behavioral health issues. And so oftentimes our fire department requests our crew team as well.
So we have another question here. Caitlin from Olympia wants to know about healthcare facilities. And MARILYN, you worked in healthcare for a long time, so maybe you can start with this one. She says, I think the inclination is still to call 911 when they think someone is in a crisis. How are we getting the word out about crew to these community organizations so they know that crew is an alternative resource?
That's a great question. A lot of times, for those of you that don't know, we get inquiries from via email, phone, through our website, family members, caregivers, friends, coworkers. This person is in crisis and I am looking for them and I need to get them help. And oddly enough, that's a huge question in today's world, because there's really no book that says learn about mental illness. People don't. You just don't get that kind of information. So they turn to NAMI. As far as medical facilities, I try to get a little bit of information about what's going on with this person. If they were in the Olympia area, I would refer them to the crew team and try to get as much information to roll over to them as possible. I can give you an example. I got a call from Idaho, a family member looking for someone who was last seen in downtown Olympia. I rolled that information over to the crew team. They were able to actually identify this person and say they were okay. And I think that's a huge piece for family members and caregivers that are distanced from that person and unable to locate them and help them. For people that live locally and want to get care for that loved one, it's very difficult. I hate to jump into a bunch of numbers. There are not a lot of beds locally in Thurston County or in the state of Washington or for the country for that matter. And so folks that are in crisis, we are traditionally turned to our emergency rooms. Not the best place to get care for people in crisis, obviously for lots of different reasons, COVID and lack of beds, lack of staffing, huge amounts of barriers. We're fortunate we do have a larger facility here in Thurston County called South Sun Behavioral Health Hospital, which is a dedicated mental health hospital. I think it's licensed for 90 beds, but because of staffing, I think they routinely probably run about 50 to 60 patients. That's an option. It's extremely difficult. I hate to say in today's world, they say, can you deal with it outpatient? Well, that doesn't always work, right, Ann?
Oh. Yeah, I mean, just to piggyback on what MARILYN said is we do communicate really closely with St. Pete's. Oftentimes, folks are in the ER and they're getting discharged, and the ER nurses will reach out to the crew team and let them know, like, hey, can you assist this person on discharge? We work really closely with Valley View at the Community Care Center, especially our Familiar Faces program. I'm always overwhelmed with the opportunities and the engagement that the folks down there have with both our crew team and Familiar Faces. But like MARILYN said, like, it's terrifying and saddening to know that there are, family members that are not in Olympia. And I just had an email this week from a daughter who her mom needs to be stabilized, and she's in the Midwest and her mom is in Olympia. And just knowing that there are folks that are like keeping an eye on other people's loved ones and communicating that back and saying, like, here's what's going on. It can feel really isolating to have a family member with a mental health crisis. It can feel extremely frustrating. As MARILYN said, there's no book on, like, you've got a family well, I'm sure there is with NAMI. So MARILYN, I'm sorry, but it's super frustrating. The way the system is built, it's complex. It's a Rubik's Cube. It takes all partners to be hands on deck to really sometimes see successful outcomes. And we don't have enough just crisis stabilization beds in Thurston County.
Several readers asked about training. So Anne, maybe you can talk a little bit about this. James wants to know, what training and qualifications do members of the unit have? And also, what additional training or professional development would be useful?
Yeah, so we really hire on experience over education. I've been super fortunate to have 5 out of our 6 original crew team members have been with us since day one. And then we saw Teal Russell from the city transition over when we had an opening. And now we're really faced with, like, what does onboarding and training look like for the expansion? And we've got someone starting next week. We have a 6-week onboarding process for new crew team members that are coming on board. And really, we route a lot of our training out in the field. And then we do continuing ed kind of training for all of our crew team and Familiar Faces around de-escalation, motivational interviewing, trauma-informed response, body awareness, scene awareness, everything that our employees like roll up to me, we embed in our twice monthly training days. So we have overlap days 2 times a month. And we really encourage our team members to come to us with their training ideas and options. A couple of them just went through crisis intervention specialist training, anger management training. So those are the types of trainings that we have. I think our greatest strength is hiring folks of really diverse backgrounds. We have a crew team member in their 60s. We have crew team members in their 30s. We have a lot of lived experiences, which really is better than the classroom in my humble opinion. And we have folks that really love what they do. They love this this clientele. They love this community. So that's where our strength lies in hiring and training.
So we also got a number of questions about what resources are out there for people experiencing severe mental health crises who may be evaluated for involuntary treatment. I know that's not something that Crew does. So Anne, can you kind of just first clarify like what Crew does and what Crew doesn't do with regard to situations like that?
Absolutely. So everything that Crew does, as you mentioned, is free and voluntary. So that is very different than the Involuntary Treatment Act, the ITA rules around someone that might be gravely disabled or harm to themselves or others. What we saw during COVID, and I'm guessing I'm going to lobby this back to MARILYN after I respond, is that we saw folks that had a lot of recovery services in place and a lot of community in place and some stabilization in place really fall apart during COVID. And we saw folks get more and more acutely mentally ill. Substance use went up, as we know. And so what we found is our number one referral for the Crew team was to folks called DCRs, or designated crisis responders. So when somebody hits that threshold of really needing an involuntary hold, a DCR is a person in our community that can do that. And so we applied for a grant as the PD and got funding to house a DCR here at the Olympia Police Department 40 hours a week. And it's been a game changer, because when you can do evaluations in the community, you're freeing up law enforcement to respond to other calls for service. It's less traumatic on the community. It's less traumatic on the client. And so we do have a DCR on house that can go out and do those assessments. And we definitely have seen an uptick in the acute situations.
MARILYN, do you want to add anything to that?
Yeah, kind of from my high level view. And I like to say I'm in the mix. I have an adult son with bipolar disorder. And looking at the involuntary treatment process and kind of what's happened with COVID is we were so short on services to begin with that when the pandemic hit, it kind of, I like to say, collapsed or pancaked on the people that are kind of the real fragile folks that were marginalized to begin with, have serious mental illness, as we refer to as SMI. We're barely getting by. And so those folks were really lost housing, lost services, unable to connect in our connected world, to see their therapist. Doesn't work with people with serious mental illness. Every barrier you could think of happened for those folks. Very tragic. A lot of people who are living with their families due to all this tremendous stress and anxiety everywhere, that they were not able to continue living with their families or in their living situations, lost providers, and it was just kind of a general collapse. And I'm sure Anne could speak more to the flow of people back onto the street, overflows out of hospitals. It's definitely a real crisis. We hope is getting a little better with time.
Some of our readers actually shared some personal stories in their questions, and several readers asked what to do when a family member is completely out of control, but the police department will not transport them to involuntary treatment. A couple of examples. Samuel from Olympia shared a story about a family member who had a manic episode that ended with him in the emergency room and without a home. And so he asked, why is it so difficult to get people help right now? And Elizabeth in Tumwater had a similar question. She said, what resources are available to families in this situation? MARILYN, maybe you could start, because I know you hear from a lot of families who are in similar situations.
Yeah. I can kind of start that conversation. So nationally, NAMI is really big on education. And again, when you're in a crisis, it's not the time you're going to get that long-term education, right? It should start when your loved one, hopefully, is starting some form of treatment, or you found out they have a mental illness, and you can start that kind of onboarding of education. In a crisis, there's not a lot you can do. Safety is always the number one concern for NAMI, for not only the individual with that mental health condition, but also their family members, friends, coworkers, anyone around. We teach a lot of, it's a portion of all of our trainings when we talk about de-escalation and giving time and distance and space. I can't say enough about that. So it's a long-term learning process, and NAMI has lots of classes and lots of resources, everything from a really great first read book called I'm Not Sick, I Don't Need Help, which was put together by a psychologist named Dr. Amador. It's recommended reading for anybody whose loved one or friend is starting to show signs or symptoms of a mental health condition. It's a long-term it's a long-term process, but again, when you're in the crisis, there's not a lot you can do but back off, give time, space, get the proper people on board. I mean, I can say as a family member, my son is 6'1", he weighs about 200 pounds. When he's in a manic space, I back off, give him as much time, space, and energy as we can to help him get to a better place, and whatever that looks like. So again, starting the long-term process is important of learning how to cope.
Yeah, and I feel for family members right now. It's heartbreaking. And so we've been really creative in what we've been trying to do. I think what we've seen is our calls are a lot longer in duration right now because of the lack of ability to, we don't transport people involuntarily, and we don't put hands on people in a power over way. Like, you'll see crew team members hugging people, but we don't, everything we say and do is free and voluntary. And so there's a real shift in dynamic when you're power with people as opposed to power over people. And so that's why it's like really important to know, like, in this situation with this individual, what skills are needed, what resources are needed, and what authority is needed. And there are times where you do have to push that button and call the DCR and have the person, for their own safety or the safety of others, involuntarily detained. I know it's super duper frustrating for community members right now that are getting a response that folks won't go hands-on and assist their loved one to get to the hospital. I know that folks at a way higher pay grade than myself are hopefully working on some adjustments at the legislature or just some other problem solving. But we've just been really creative in how we've been communicating with folks that are in an acute crisis and trying to assist them in getting to the ER.
Another one of our readers asked a similar question about the legislative changes, which we've sort of been talking about just now. Has that affected crew in any noticeable way, Anne?
It's just that honestly, more detainments are coming out of the jail, which is, I think, the opposite effect of what really the legislature wanted. Because of the secure transport, the law enforcement assist. I will say, though, like, the best thing about having a DCR in-house or just having relationships and trust with partners in the community is that you can have these conversations beforehand. So we had someone that got involuntarily detained last night. There was communication constantly throughout the day between the DCR and the crew team. There was conversations between myself and the lieutenants here at the PD. We were able to safely transport this person to St. Pete's to get medically cleared. The BHO had worked their tail off to secure a bed in Lewis County for this individual. And so really, it can happen. It's just that all of us are really having to come to the table and problem solve and communicate more clearly on what each of our roles are in those scenes.
I have a thought on that.
Please.
Having been through watching the detainment process with my son on multiple occasions, it's a brutal process for that person that's experiencing, as well as the family members and friends or coworkers or whoever is around. And it's a very tenuous process. The DCRs do a great job. The staff in the emergency rooms do a great job. Unfortunately, with the stress on the system, people have a tendency to be rolled out quicker than they should be. We have all sorts of interesting laws around HIPAA that do not allow information to be shared. So many times, just in my own experience, my son got sent out of the ER in a cab. no way for me to know. And that's a huge stressor for family members and caregivers. They don't know, are they coming home? Are they on the street? Yeah, so there's just so many components to the ITA process, and getting that next steps. And NAMI really helps to teach people what to say, what not to say, how to get the proper paperwork in order so you can advocate for that individual, like with the durable power of attorney for healthcare, and to walk them through the next steps. And if they are detained, continuing to have that conversation with hospital staff, and hopefully a provider that maybe you had on the outside that you can coordinate care as they leave that detainment. And again, the average person doesn't know this process. So it's really important for people to reach out and get the support that they need while that's happening.
It's incredibly traumatic. And I think that's why detainment numbers are incredibly low, because you're stripping someone of their civil liberties. And that's a high bar. You're saying that you can't make decisions for yourself. And oftentimes someone is not in a state to, it's called involuntary for a reason. Oftentimes people aren't like, yeah, I recognize this in myself right now. And so it's really traumatic for the community to witness something like that, and for family members.
And just to say that the hospital process in itself is unique to healthcare. The average person doesn't know what goes on in a hospital emergency room. It's a really hard place to work. I commend the professionals that are hanging in there. But again, for them to take the time to inform family members of what's going on, and all the layers of referrals to different providers to get this person out. And if there's ITA, there's legal components. It is so intensely layered that a lot of things fall through the cracks unless you're really, really prepared for it. And I can honestly say personally, my son's been detained a lot, and I have a lot of paperwork in place, and I've learned to coordinate through systems, but that's been like 14 years of talking to professionals and getting the right paperwork in order. And I have to say this, one of the most important things is to have that conversation with my son. When he was very, very ill, like Ann talked about, they don't recognize what's going on. It's a medical term called anosognosia, which means they lack insight into what is going on. They're just scared and being trapped, and their civil rights are taken away. And what is going on to me? It's very frightening. And so it's important that I have that discussion with him. And it's been an ongoing thing. I've had lots of NAMI training. He's had lots of NAMI training. Now we have those conversations. He'll say to me, Mom, I don't ever want to go back to the hospital. And I said, well, we're working on that. And we've provided professionals around him. He has a great group with behavioral health resources here in Olympia. It's called PACT. And I wish we had 4,000 more slots for this program, because it's wraparound for him. It's a team of professionals, a therapist, a nurse practitioner, a folk rehab, peer support specialist that get him what he needs to be successful. And now he's out of the system. He doesn't deal with emergency rooms and ITA and the jail. He doesn't deal with that anymore, because he has the right amount of services it takes to make him successful. And that's where I wish we could go with our money. And Ann's group, of course, too.
Marilyn, you mentioned emergency rooms, but there's lots of other facilities too that come into play here. Can you talk about some of what resources are out there and what resources are not out there that we could really use? In terms of facilities,
yeah, we have very little hospital beds. I always like to throw out the math. Okay, if we have 280,000 people or whatever live in Thurston County, and we have less than 50 beds or less than 100 beds, that doesn't sound like a good piece of math, does it? And so not having that bed there when you need it is a problem. A friend of mine wrote an opinion to the Daily Olympian a while back, and she said, if you walk in through an emergency room door and you're having a heart attack, you're swept into the back. Lots of people help you and assist you to figure that out. You walk in through the door of an emergency room, and this was pre-COVID, people look at you and go, what do you want from us? It's kind of a different, what can we do? The services are so limited. We've got to move back into preventative care and education, and putting the brain back into the body and treating it like it's a health condition. And mental health conditions are just that, they're illnesses. So yeah, we don't have a lot of bed space. And I get calls from people They may be sitting at a hospital in a parking lot, and they're like, there's no beds here. Where do I go? So you start to branch out. You start calling Tacoma, Pierce County area, Kitsap County. I know people have drug their loved one to Oregon, particularly around pediatric care. We have almost no pediatric psychiatric care. And so specialized programs for eating disorders. I was working with a family that had to take their loved one to Colorado. There's nothing. It's a part of the healthcare system that we need to revamp.
And all roads lead to the ER, though. Like,
correct.
You have to go to the ER first, which I don't
Yeah.
think people understand. You have to go to the ER first to get medically cleared. Correct. And then you can go to South Sound or Telecare or another location. So it is overwhelming our ER. And then they only have 3 crisis beds at St. Pete's. So you'll see people in hallways. It's just, it's not ideal.
Traumatic.
It's traumatic. That's what I was going to say.
Yeah.
We did get a question in the chat here, and I do want to encourage people to continue submitting questions. And this person is asking something that a lot of other people ask too, which is what happens when crew is not available? How are calls responded to then? And then a similar question we got from a reader is what happens with people who are frequently needing intervention on a daily basis or calling multiple times? So Anne, maybe you can
Sure.
explain about that.
Absolutely. So currently, if crew is not available, an officer or fire will respond to the individual, or there'll be a phone detail. So the dispatchers at TCOM do a really great job of kind of pulling out information from the caller to see what the right response would be. Oftentimes, I know this might sound controversial, but our officers do bring a lot to a scene besides a gun. And so some of our officers are the greatest folks I've seen at de-escalation or problem solving or resource obtainment. And we'll get emails. So I'll get an email, or I'll get a text, or Anna or Teal, our crew supervisors, will get a follow-up email from folks like, hey, responded to this person last night. They're not in a good place. I told them that the crisis response unit would be following up with them. Sometimes our officers will be putting people in hotels, and then we'll get information about that. So there will be a response, and hopefully there'll be a crew follow-up. And our crew leads read the TCOM reports. Some job of following up with folks as well, especially those family members, like MARILYN said. So we saw somebody that their adolescent child got detained. And I'm a mom of 3 teenagers, and I can't imagine the stress and the worry and the shock and crisis that I would be in if one of my kids had a mental health crisis and was detained. And so Anna, our lead, called this mom and was like, hey, we're a resource. We can talk you through things. Sounds like this is what happened last night. Let us know how we can assist. There are folks that are in chronic crisis. We have one individual that calls 911 probably on average 50 times a day to report things about China and nuclear war and homeland security. And that really puts a strain on our dispatchers. And we have folks in the community, that aren't calling 911, but are having frequent contact with traditional first responders, when really that's not the consistent folks that need to be showing up for them. And so we do have our Familiar Faces program. So crew responds to people in crisis or in distress or in a problem-solving moment, in the moment. And that's a solution that works in that moment. But then we do need solutions that last, like the PAC team that MARILYN said, like Familiar Faces, where we offer permanent supportive people to people, because that's what people need. I'm going to sound like a Dr. Seuss book here in a second, but people need people. And that's what we offer with our Familiar Faces program. And they work super closely with crew.
Thank you for saying people need people. I can't state that enough. I get phone calls, and there'll be spouses and parents and adult children. And just to be able to talk to somebody, I love the opening statement. Well, this is really hard to say, and you probably won't understand it. And I'm like, give me a minute, go for it, and I'll let you know if there's something new. And it's like, they are scared. They don't understand. They just need someone to say, it's going to be okay. There's a plan in place. We can help you. We can give you resources. And these are these are medical illnesses. This is nothing you did. This is nothing they did. It's a really important reinforcement. And we have a kind of a national campaign. It's okay not to be okay. And people are stressed and they need to know that it's a normalizing experience. You'll get through this. And you know that they're not alone.
So we have one more pre-submitted question here, and then those are the end of my questions, unless anyone posts any more. So I'll just make a last plea for anyone who has questions that they want answered to post them now. Last question, and I know you don't have numbers sitting in front of you, but Keith wants to know if you can give an update on how many individuals are being diverted from arrest through the use of the crew team. So again, you're probably not looking at a spreadsheet right now, but if you could talk generally about the idea of diversion and keeping people away from the criminal justice system.
Absolutely. So, you know, like preventative numbers are the hardest numbers to ever kind of come up with. And so I would say on average, crew in its current unexpanded form responds to 2,600 individuals or contacts per year. And like I mentioned to Brandon when he was out with us, is like really a lot of that pro-social work is really like the best 911 call is the 911 call that never gets made. And so both those programs, Crew and Familiar Faces, are really working at diverting folks from the hospital and from jail. And we do that by transporting individuals and offering them crime inoculators. Like if you're cold and you're hungry and you haven't slept, like you're probably and you've got mental health and substance use, you're probably close to snapping and yelling at somebody and doing something that might get you in trouble. And so any kind of supports that we can offer folks to do that kind of like crime inoculation is really what we're going for. And so I would say the numbers are just going to keep on growing. We really have come to terms with like myself as like understanding that I only exist in this community that we serve, and this community that we serve has a lot of poverty, has a lot of mental health, has a lot of disability, has a lot of low-level medical conditions. And so we keep on trying to respond to those folks and offer supports in those ways so that they have less contact with traditional first responders.
MARILYN, anything to add to that?
No, I just, kind of when I do my spiel across the county, I tell people not to be silent. I think it's probably one of the most devastating side effects of mental health, that people live in silence. They live in an unsafe situation for themselves and for others. There's so much stigma and shame around talking about mental health and substance use. We've got to break that. We have got to stand up and talk about it. People don't have problems talking about diabetes and cancer and MS, but we seem to have a problem talking about brain disorders and mental health conditions and substance use disorder. Reach out for help, reach out for support, be honest. I don't care who, if it's somebody you don't know that lives down the street. I had an incident in our office the other day and I ended up talking to the neighbors out front, and it's like, please acknowledge that something's not right, and that you are reaching out for support and help, because you're not only helping that person, you're helping yourself down the road. So don't be silent anymore.
Anything I haven't asked, just in closing, that's important for people to know? Either of you, any closing thoughts?
I just want to say I appreciate the crew and everything they do. I watch a lot of our national webinars, and the Cahoots model is really the #1 model across the country. Part of my heart feels good about non-law enforcement personnel going out on mental health calls. And again, that's based on my own personal experience, because about 90% of everything that's going on with people, in my personal opinion, again, around a mental health issue, can be solved with sitting down and talking to somebody, trying to get resources for them. I mean, and I appreciate, Anne, you said in the beginning, a lot of this is poverty based. You don't have a place to go. You don't have clothes. You don't have food. It's like, those are huge frustrations for a human being, any human being. And so yeah, I just appreciate it. I wish we had more of it. If I win the lottery, Anne, you're getting it.
Yay!
Yay.
I'm really thankful that I mean, I adore MARILYN. I've been working with MARILYN since before I came to the city. And I think Olympia is super blessed in the investment that Olympians have in their community and the engagement that Olympians have in their community. You're not the two people or the three people I'll loop you in on this, Brandon, that are on the screen love what they do and the people that they serve. And so I would just applaud the city of Olympia in general and folks that are doing this work. I'm one person in a larger team, and I have the greatest team members possible. So the shout out goes to them.
Well, thank you both so much for being here, really illuminating. And thanks again to our readers for submitting great questions, some really perceptive stuff. And just one final note before we close, if you thought this conversation was valuable and you'd like to support the Olympian going forward in hosting important community conversations like this, the best thing that you can do is become a subscriber. And you can find more information about that at theolympian.com/subscribe. Thanks again and have a great afternoon.